Great, thanks so much, Rob. I really appreciate being invited along for this conference, and I'm so impressed with this high caliber of speakers that you have. I feel humbled to be among them, so thank you very much for inviting me. So today we're going to talk about opiate use and hyperalgesia in the time of COVID-19. I have no relevant disclosures. I do talks for all sorts of organizations, all CME accredited. So the objectives for this talk, we're going to overview the role of substances in pain sensitization. We're going to highlight the key issues regarding opiate use while physical distancing during the COVID-19 pandemic. And we're going to review assessment and treatment protocols adapted for telemedicine. And mainly I'll be giving resources for those. And then we're going to list the temporary changes to the National and Provincial Controlled Substances Act so that you, clinicians among you who are prescribing, know how those changes are, and patients may also know about what changes their doctors can make if needed. And then we're going to explore some online resources for patients and for clinicians. All right. Get the time here. All right, I see where I'm at. Okay, so the first concept I really want to start with is this concept of hyperalgesia. The concept that there's all sorts of things that can add to one's pain sensitization. And we've heard about a lot of these things through the conference over the weekend. So we've heard about trauma and anxiety states that can alter one's pain perception and one's anxiety threshold. Also, injury, repetitive injury especially, can alter one's pain threshold. And also another area that many people aren't aware of is that there's many substances that not only give you analgesia when you acutely use it, but on withdrawal or over time, it can actually lower your pain threshold. Alcohol is one of those substances. So binge intoxication can not only lower your pain threshold, also your pain tolerance, how much you can take, but in addition, it can make you more anxiety sensitive, a condition that Dr. Rieb and colleagues have called hypercatephia. And all three of these states that you see on the top part of the oval can predispose you then to the three things you see on the bottom: alcohol or other drug dependence, anxiety disorders and depression, and chronic pain disorders. And certainly in clinical practice, we see people disproportionately who have the top three and who then present later with the bottom three. I'd like to focus now on how opiate plays a role in that system. So many people know about some of the positive effects of opioids in terms of pain relief, end-of-life care, COPD, severe breathing management, but the negative side effects of opioids have been more at play in the media and in our medical literature recently. However, one thing that isn't talked about much is how opiates themselves, though they can relieve pain acutely, over time can end up causing some pain, shifting of your pain threshold where you first feel pain, and also your pain tolerance, how much pain you can actually take. So if we look at the classic view on this, that opiate treatment creates cellular mechanisms that then create pharmacological tolerance, where the receptor itself becomes insensitive to the effect of the drug. And there's many mechanisms behind this. And that's what I was taught in med school. But now we know there's just this whole other thing going on. And I've put it in the oval here from Dr. Mao's work, opiate-induced hyperalgesia, OIH, on the slide. So I'm going to show you on the next slide, there's about 21 or more different areas in the nervous system that get altered when exposed to opioids that may actually add to people's pain experience and actually drive the desire to take opioids, because in withdrawal, you may actually have even more pain. So both pharmacological tolerance and opiate-induced hyperalgesia lead to apparent tolerance, a worsening pain state. And so I was always taught, just escalate the opiate dose. Really, there's not a problem. There's not really a ceiling effect. Let's just go up. And I think that has led to a lot of problems throughout the world, actually. And it also makes it hard when people try to come off this. If they come off too fast, then the opiate-induced hyperalgesia effects are left, and people can have a worsening pain state. So let's look at the pain sensitization, opiate-induced hyperalgesia. This is from Ravat and Ballantyne, 2016. It's a nice model showing that these are all things that you see on the screen get affected when opioids are added to a system. So the peripheral nerve and the DRG is the dorsal root ganglion. There's different neurotransmitters affected there. Also within the spinal cord, that middle part of the diagram, both neuronal changes, particularly in the glutamate system, the NMDA receptor, also in the glial cells that we used to think of as just support cells. They actually do a lot of communication with nerves, and the toll-like receptor 4 on these get altered when opiates are applied, and they can release inflammatory cytokines onto neurons. So it's the actual opposite of what you think you want, which is pain relief. It can actually add to inflammation on your nerves when opioids are used over time, or in high doses, or in binge patterns. All of these things can affect it. And then there's brain changes in the periaqueductal gray, the raphe, and other places. So both your ascending and descending tracts, the brain and the spinal cord, are all involved in this. The other thing that can happen is not just taking the opioid, but when you take the opioid away, you no longer have the pain relieving part of the opioid, but all the changes that happened that your nervous system adapted to that may make you more pain sensitive can take weeks or months to remit. In one study of chronic back pain with people on opioids, not for addiction, but just for pain, it took up to 5 months for their hyperalgesia to settle. So on cold pressor test or on heat testing, it can take weeks or months for that to settle. And that's very confusing to patients who, when you bring them down too quickly on an opioid, may have all this rebound effect and think, I absolutely have to go back up on my opioid. Sometimes they do need to, but sometimes there's other ways to manage that, like slowing the taper or holding for a while, for example. So that unmasking is one thing. And then there's also the second thing that happens when you withdraw from an opioid is that you get release of noradrenaline and adrenaline. So these catecholamine cascade. And we now know that these stress neurochemicals can actually cause neuroinflammation and neuroimmune changes that lead to pain. So your patient isn't crazy when they say, you know, when they're stressed, they have more pain. It's not simply that mood alters pain, but you actually get neuroinflammation and neuroimmune changes with that stress. So we want to taper people at a rate and that doesn't trigger a lot of stress response. And we want to teach a lot of things, be that, you know, we learned about yoga, we learn about meditation, about mindfulness, about breathing techniques. All of these things help to lower that catecholamine release, that stress response, and can actually help mitigate some of these effects. Another challenge is during withdrawal, you get this tanking of your dopamine. If you've been on any drug that increases dopamine, like an opioid, a benzodiazepine, alcohol, cocaine, whatever you're taking, all of these things, if you stop them suddenly, you get a drop of dopamine, which leads to depression, grief, loss, lethargy, amotivation, and you get this boosting of noradrenaline. Like in alcohol withdrawal, you get noradrenaline release. In opiate withdrawal, you get noradrenaline release. And that adds to anxiety, insomnia, worry, perseveration, agitation, aggression, activation of traumatic memories. I've had patients tell me every time they get pain at an injury site when they've tapered too fast, that brings up the memory of the actual injury that they had that may be a traumatic event. And the memory and the pain all overlap and get intertwined. So this led me to do some research that we had published in Pain in 2016. It was a multidisciplinary, it was a mixed methods study where I looked at people who had an old healed injury site that was usually pain-free prior to them ever initiating an opioid, either for pain condition or for an addiction condition, and who on withdrawal not only had pain at their chronic pain sites, but got pain at this healed injury site that then went away after their withdrawal was over. I was seeing this in clinical practice and I was thinking, oh my God, this is like something that if we can measure or define this may be a clinical measurement of hyperalgesia in patients. So you don't have to shove their arm into a vat of ice water in the office, right? So this is an open access link. I paid for it to be open access, so please use it. It cost me a couple $1,000s to do that, so go ahead. Just download that for free. And in here, since it's mixed method, you'll hear from the patients about what their lived experience was and what they thought was going on in their bodies. And it's a really fascinating read. And I learned a lot about this condition from listening to the patients and recording what they had to say. So what we found in general is that healed injury sites can hurt again during opiate withdrawal and vanish when the withdrawal is over, a phenomenon we called withdrawal-associated injury site pain, or WISP, because it comes on and goes away like a will-o'-the-wisp. Participants in this mixed method study reported that WISP was reminiscent of the original injury in quality of pain and often intensity of pain. So it felt like they were having that original injury again. And it was emotionally aversive. So they had this, sometimes even PTSD type symptoms related to it. And on average, it lasted 2 weeks post-opiate cessation, but lasted over a month in 18% of patients. WISP contributed to relapse to reinitiation of opioids despite their desire to be off, and it was a barrier for their detoxification. So 44% did relapse. So beyond opioids, NSAIDs and gabapentinoids relieved this WISP, as did many full detoxification. I then went on with colleagues to publish a detailed case study from that report that I followed along, someone who had benefit from buprenorphine rotation. And again, it's looking at that link between opiate-induced hyperalgesia and the WISP phenomenon. Again, this is an open access journal. You are welcome to download it and take a look. It gives you a language also with which to talk to your patients or to understand your own pain experience. And then we've just published this year in Drug and Alcohol Dependence, a study looking at prevalence and correlates of WISP among opiate-using people who inject drugs in Vancouver. So we looked at 631 people who are daily injection opiate users, and we found that almost 50% of them had the WISP phenomenon. And among those, about 40% let me rephrase that. Almost 50% had an old healed injury that was usually pain-free. And of those, about 40% had experienced WISP, pain returning to their injury site during opiate withdrawal that then went away after the withdrawal was over. And the vast majority of them, over 70%, said that this influenced how they used opioids so that they would reinitiate. So this could be one of the hidden drivers to the opiate epidemic, and also one of the reasons that it's hard when patients are tapered too fast by their clinician to come off an opioid. Here on the screen, you can see some of the preclinical and clinical trials, so animal and human trials that look at mitigators of opiate-induced hyperalgesia and withdrawal-induced hyperalgesia. And to note, the things in blue are things that we have used for decades to treat opiate withdrawal. I want to do a case with you. So I'll tell you about Mr. X, who is a gentleman I saw first in the multidisciplinary pain clinic that I work in, and later I got to see him in the drug and alcohol treatment center I work in. So I treated him in both locations. So he's a 56-year-old left-hand dominant sailor seen in the fall of 2018. He had a right rotator cuff tear and repair in 2001. In 2011, he had a fall at work, a complete re-tear of his right rotator cuff. 3 subsequent surgeries just tore right through them. So he was left. They said, no more surgeries for you. He had pain 6+ out of 10, depression, insomnia, sleep apnea, hypertension, and new onset atrial fibrillation when I saw him. Morphine, extended release, 400 milligrams a day. He'd been on for years, but really wasn't coping all that well. His family physician decided to taper him, but 2 months prior to me seeing him, had dropped the client abruptly from 400 to 300 milligrams of morphine. And then 1 month before I saw him, dropped his gabapentin because he had sleep apnea, dropped his gabapentin from 3,200 down to 1,600 all at once. The client's response to that was he had elevated pain, and he had noticed when he binge drinks that his pain went down, which is true. That's the lived experience of patients. There's a dose response curve to the more alcohol you drink, the higher the analgesia in the moment. However, this also can induce hyperalgesia, as we'll see. So his binge drinking on the weekend became daily 4 to 9 drinks, and he did screen positive for an alcohol use disorder. So what are the treatment options? Residential treatment is most prudent for detoxification of alcohol with a CWA protocol under medical supervision for a gentleman with all of his comorbidities, and opiate rotation to buprenorphine and naloxone using a microinduction technique so we don't stimulate problems with his heart. So he did a full 42-day inpatient treatment program, and on discharge, he was on buprenorphine with naloxone, 4 milligrams a day, pregabalin 150 twice a day. He was on an anticoagulant and beta blocker for the AFib, and we provided him with a naloxone kit. So if you had asked Mr. X before detoxification, it's not true detoxification, it was opiate rotation and lowering of the dose. So sometimes there's a sweet spot where the dose, but he's almost off. He would have told you before we converted him that he needed more morphine to treat his pain, because that was his lived experience, that he'd done better on a higher dose, that he needed alcohol to get by with the pain, because that's his lived experience, which is completely valid. And he was considering adding cannabis to help his pain. Yet after this detoxification, he reported having less pain, rated as just 0.5 out of 10, and the deep ache was gone. His sleep was 7 to 8 hours a night, and he reported being more clear-headed. He realized he was an alcoholic. That's his term, not mine. So we say alcohol use disorder, and likely so were his parents. He wanted off all opioids to advance in safety-sensitive jobs. Since he was a sailor, he wanted to become a captain, and he saw treatment as a life-saving intervention for him, saying that it's amazing. And certainly this is an example to illustrate a point. Some people respond better or worse than this, but it's just to know that this can happen. And certainly in the pain literature on gentle opioid tapering, most patients have the same or less pain when they're tapered down or off. About 10% have worse pain. If we want to talk to patients about hyperalgesia, I would recommend the main messages be substance use can not only relieve pain, but can cause pain. Like if we look at rat studies with alcohol, even 5 days of daily drinking can cause hyperalgesia in animal models. Binge or daily alcohol or opiate use can alter the nervous system to be more pain sensitive, hyperalgesia, and more stress sensitive. During alcohol and opiate withdrawal, pain can flare even more and intensify at old injury sites and sometimes provoke memory. All right, so that's the hyperalgesia part that I added at about 2 o'clock in the morning last night because I thought it looked like it fit in better with the rest of the conference than what I was going to talk on, which is this. I'm now going to switch gears and go into COVID-19 pandemic prescribing with opioids, some of the changes we need to make. So new issues arise, and longstanding ones can be exacerbated during COVID-19 pandemic and isolation protocols. Many people may stockpile meds and substances and thus have more availability and access. And we've seen that in British Columbia, at least, drinking has gone way up during the pandemic. Supply chains can get cut off abruptly, which can be another problem. And the quality of non-medical supply can then be unreliable or more toxic. So we've seen an increase in overdose deaths as well from opioids. Many people turn to non-beverage alcohol and non-medical substances to relieve that withdrawal or to treat pain if they have lack of access to their substance, be it licit or illicit. Psychosocial issues like homelessness, violence, and sex trade can all impact on people's ability to either access or to stay safe in that setting. Sharing paraphernalia, bottles, cigarettes, crack pipes, in addition to the classic needles. Some of the key points that the National Institute of Drug Abuse mention regarding their COVID protocols is because it attacks lungs, the coronavirus could be an especially serious threat to those who smoke tobacco or marijuana or who vape. People with opiate use disorder and methamphetamine use disorder, which often are paired, may also be vulnerable due to these drug effects on respiratory and pulmonary health. Additionally, individuals with a substance use disorder are more likely to experience homelessness or incarceration than those in the general population, both of which are risk factors to get COVID. And these circumstances pose unique challenges regarding transmission of the virus. Some of the digital access and treatment that we have, care to underserviced regions that are needed is great, and we've expanded that, and hopefully that will continue post-pandemic. We keep patients and clinicians physically distant. The advantage of that is that they can't infect each other. Facilitate the use of validated tools. There's some studies that show if you're online with a patient, you may be more likely to pull up online a validated tool and say that to the patient than if you're just in the room with them. There's novel biomarkers with gait, speech, and breathalyzers that can be used, like wearable sensors on mobile devices that can help with medication adherence, relapse prevention, and real-time interventions. For example, tracking visits to the liquor store, collecting breathalyzer information, and then having a counselor or MD or NP have an intervention that is supportive for the client's recovery goals. So where do we start? We first want to assess and make a diagnosis. That would include checking PharmaNet or your equivalent, interviewing and examining, screening with a validated tool, and say, is this just substance use or is it a substance use disorder? So you would take some history around prescribed medications and the route that they use it. Do you ever chew it or snort it or inject it? You know, these kind of things. And then non-medical use of the substance to mitigate anxiety or pain or to force themselves into sleep or when they're angry, this kind of thing. We want to see, do they have a full pain disorder or just mood and other disorders or substance use disorder, and how functional are they? Do they have physiologic dependence, and look at if there's a withdrawal syndrome present, how severe it is, and also what their comorbid state is and if it's life-threatening. So for example, their life circumstance may mitigate doing a rapid taper on someone. They may have mental health issues. They may get violent or suicidal if they're tapered too fast, or they may go to the street for use, which is not the intention of tapering. So let's talk a bit more about opioids. Some of the issues is we want to ensure stable supply of medications for chronic non-cancer pain. In the pandemic, we want to make sure there's longer scripts with part-filled dispense and bubble packing if needed, keep the users out of clinics and hospital if possible, prevent withdrawal and allow for a steady supply of unadulterated medications, get as many people with opiate use disorder as possible off non-medical opioids onto prescription opioids, transition from injection use, including those who are on IOAT, so injectable opiate agonist therapies, over to oral routes if possible, so they don't have to go in all the time, and they lower their risks, and to assist with social needs, housing, safety, harm reduction. There's some changes that Health Canada have temporarily made to exemptions to the Controlled Drug and Substances Act. So it permits now pharmacists during the pandemic to extend prescriptions without speaking to the doc. So some emergency supplies can be extended. Also, you can transfer even controlled substances to another pharmacy, which wasn't available before. Also, we can deliver controlled medications at the pharmacist's discretion without having to talk to the doc when it's safe. Also, but usually they do talk to the doc, but you know, sometimes the patient will call and say, look, I just got screened positive for, or I just am being screened for COVID. I was told to go home and isolate. I can't get to the pharmacy, so they can deliver. And it permits prescribers to give verbal or faxed orders, but in British Columbia, we want to send the original in the mail or courier it. And when we prescribe in the pandemic, other changes that can help is home induction if someone is getting induced onto buprenorphine. For stable patients, we can write longer. And for slow release oral morphine, you might omit that sprinkle in order to reduce time in pharmacy. And with methadone, you can extend take-home doses beyond what the colleges usually allow if the patient is stable. And if they're using illicit substances on top of either pain medication or their opiate agonist therapy for an addiction, or they can't tolerate the medications that they're being given, there is consideration to provide hydromorphone 8 milligrams in a titrated dose so that the patient can use that at home instead of going to illicit street. There's caution with this. We did create an opiate epidemic as with physician open prescribing, so we may do some harm with this kind of prescribing, but in the short run, if someone is at risk and using street substances that could kill them, I think that there is a role for this kind of intermediate mitigation. Typically, opiate tapering is not an emergency for chronic non-cancer pain. We want to stress that likely in the pandemic, it's not the best time to taper somebody off opioids unless their supply is disrupted, their safety sensitive work, or the patient asks. As outpatients, many patients with chronic non-cancer pain can drop 5 to 10% every 1 to 2 weeks if they're early on in their disease course and they haven't had really severe pain conditions. However, if they've been on a long time, that's way too fast. Or if they're on super high doses, that may be way too fast. So even to slow it down to a change of 5% or even 3% every month, you will get there eventually. Some of my patients I taper over 2 to 3 years. What you want to do is make a small change and let the changes, the withdrawal-induced hyperalgesia, to settle. And then make a small change and then let that settle. Because most of the time, most people who get pain relief with opioids will get so by 50 milligram equivalent of morphine, sometimes up to 100. So beyond that, it's likely that most of the pain control beyond that is actually just some degree of hyperalgesia that you're mitigating by taking the opiates. So you get some relief and then it comes on, and some relief with dosing. That's not true in every case. There's some people who do very, very well on high dose opioids. And if you have an opiate use disorder, definitely high dose opioids is recommended. Faster tapering, which can happen with opiate rotation and with adjunct medication, especially with a skilled practitioner. So what are opiate lowering strategies in those with chronic non-cancer pain if they've asked to lower, or they have a medical reason that it needs to come down, or they've had no benefit? We can either convert to long-acting opioids and taper, we can taper using short-acting opioids, or we can do withdrawal symptom management and opiate substitution or tapering. And I'm just going to show a recent study. Jane Ballantyne and her colleagues published this, looking at people who have physical dependence on an opioid for chronic non-cancer pain, but not an addiction. They don't have an opiate use disorder. And this was the decision tree about either tapering them with the substance that they have, the opioid that they're being prescribed, or converting them over to buprenorphine. And this kind of a tree can be very, very useful. And I want you all to be able to have access to my slides, and you're welcome to look at the papers and work your way through these. What about if someone does develop a full-blown opiate use disorder? You can see the psychosocial treatments, counseling, peer support, residential treatment, and recovery houses. There's also medically assisted treatment, MAT. It's also called, on the one hand, opiate agonist treatment, which you can see in the line. That would be methadone, buprenorphine, slow-release oral morphine, or in rare cases, injectable medication. And then there's the antagonist therapy. So that's naltrexone, either oral or injectable. In Canada, we don't have access to injectable readily, but in the States they do. So we're missing one of our great arms of treatment in this country. And then there's naloxone for overdose reversal. These are the different forms of buprenorphine available in Canada. Only the patch is actually past Health Canada for pain purposes, but buprenorphine was actually developed as a pain medication. They just made the marketing decision to market it as a treatment for opiate use disorder because they thought they'd have a better part of market share in that market than trying to market it as a pain treatment. However, there's been systematic reviews and scores of papers showing that it's as good or better than morphine for pain relief. So you can use it off-label for pain, and many clinicians are doing that. And it has a ceiling effect for respiratory depression. And so there's a big advantage over all other opioids. Also, the kappa receptor antagonism of buprenorphine may help with depression and may play a role in reducing hyperalgesia, as one of the other receptor that it stimulates may play a role in hyperalgesia. I've included a 𝐒𝐂𝐂𝐂 scoring here. If you are going to try to convert somebody, you can put them into withdrawal and then start the buprenorphine. This is 𝐒𝐂𝐂𝐂 is a clinical tool, and I've given you the link that the patient does themselves if they're doing a home induction. And this is the BCCSU's classic home induction after a 𝐒𝐂𝐂𝐂𝐂 or 𝐒𝐂𝐂 has been done, which again, you would start with a 4 milligram test dose and then increase by 2 milligrams every 2 to 4 hours, up to 8 the first day, and then you go up from there. However, often this is a difficult thing, so I've given you some options for modification there, starting with a transdermal patch the night before. 20 microgram per hour patch I find works really well. And then I've given you a different induction schedule for those of you who are clinicians, starting with just 0.5 milligrams, waiting an hour if no precipitated withdrawal, then giving 1 milligram, waiting an hour if no precipitated withdrawal, then going by 2 milligrams every 2 to 4 hours. And so this kind of thing can work really, really well. And this is a great paper that many of the people who have spoken here and who may be on the line, all of them I know and appreciate, did a great study reviewing novel methods to support transition from methadone onto buprenorphine and naloxone. Buprenorphine by injection has, once someone is stabilized on 8 milligrams a day, injection can carry them for a month. And I've given a schedule here. There are a few case studies anecdotally that I'm starting to hear about people who are using this for pain treatment too. So someone who is stabilized on 8 milligrams, then being able to just take a once a month injection for pain treatment. And this hasn't percolated through the literature yet, but this is the cutting edge of where we're going to go, I think. And for those who do prescribe methadone, I've given you typical daily dosing, and splitting the dose of methadone or buprenorphine can be helpful. Just to know, when people are on methadone, if they come into hospital, lower their dose by about 25% and give those in PRN, since there is a place-based association with opioids. Even animals put into a new environment, often their need for opiates can drop. And so you can overdose sometimes, even on the same dose you're used to every day in a new environment. And I have something here on slow release oral morphine and on injectables for those of you who are clinicians who go through that. Typically with slow release oral morphine, there's no take-home doses, but in pandemics, sometimes there is some exception to that. Yeah, and then just to look at, if you can't prescribe an opioid yet, someone presents with an opioid use disorder, this was the classic Clonidine detox schedule. And again, these are all medications that, or most of them are things that we know can mitigate opiate-induced hyperalgesia and withdrawal-induced hyperalgesia. And we remember our Naloxone take-home kits and our prescribing resources I've given you there, the NIDA resources I've given you, some online resources for BCCSU, Bounce Back. Yoga with Adrienne is one of the free yoga online with hundreds of yoga tapes, but it's not directly for people with injury, but people can screen through. Also for $99 a year, there are numerous, Beachbody is one example where you have access to hundreds of workouts. If usually people need to be a bit more fit than some of the patients we see, but people can find something at their level. Then Headspace, free CBDTI and things like that. There's some community resources for vulnerable populations. I've given risk mitigation in the context of dual public health emergency, and again, resources for COVID-19 and substance use. I've given you a list of partial list of resources for hyperalgesia. And that's about it for the little rapid fire talk. Thanks for sticking with me through.